Hey everybody, it's Adam Farkas. Welcome to another ODwire webinar. Thanks for coming out tonight. And tonight we got a good one for you here. It's a little bit different. We were actually just chatting before we came on the air here, just about how different tonight's talk is. So a focus on vernal keratoconjunctivitis, a case-based discussion. And so we're really excited to do this one today because it is so different. And you know, it's focusing on a topic that we just haven't really spoken much about before. So I think it's going to be a great review for everyone else. Before I introduce our speakers, I just want to remind everyone on the right side of your screen, you should see a box that says questions. And as we're going through tonight, feel free to type into that box and I'll take your questions and hold them aside until the end of the presentation, and then we'll let the speakers have a go at it and we'll answer the questions that way. So with that said, let me get the slides going here and introduce our two speakers tonight. So tonight we have for you Clare Halleran of East Coast Eye Care in Newfoundland, Canada, and Susan Resnick of Drs. Farkas, Castillo, Resnick and Associates in New York. And I think most of you here tonight are familiar with our two speakers. So these are prominent educators and authors, and you've seen them lecture on optometric topics, very wide ranging, you know, from contact lenses to dry eye and all sorts of medical optometry. So I can't think of two better folks to give you this topic tonight. And they're going to take you through some discussions of the disease process and some cases. So it's going to be really a lot of fun. So why don't I push myself out of the way here and turn things over to Clare and Susan.
Great, Adam, thank you so much. It's a pleasure to be here with Dr. Halleran. We're going to share this discussion. She's going to be leading us through the specific cases of vernal keratoconjunctivitis and her clinical experiences and some of the treatment modalities and challenges. I'm going to kick it off with leading our talk on a review of the epidemiology of this very rare but sight-threatening condition. And I'm going to delve a little bit into the clinical signs and symptoms, as well as the pathogenesis. Okay, I just want to see if I can, there we go. Okay, so as I said, it's a sight-threatening allergic ocular disease, and it's a really severe form of allergic conjunctivitis. You can see here with the slide on the right, that's an averted lid, and that's typical of the large giant papilla that you will see in patients suffering from this disease. We're going to go into a little bit more about that in just a few minutes. But in whom do we see these conditions? Basically, it is most prominent and prevalent in male children. The onset is younger than 10 years of age in most of the cases. The disease itself runs a course of about 4 to 7 years, which is very interesting. It almost burns out in a sense. There is a large predilection for males. As a matter of fact, it's 3 to 4 times greater in males younger than 20, but over 20, there's a leveling off of about a 1-to-1 ratio. And because the disease remits sometime after puberty, in addition to the gender predilection, there is some thought that hormones may play a role, but we really don't have a whole lot of information about that yet, and the prognostic data there are scarce. So let's just take a look at the global aspects of this disease. We can see that VKC is very, very rare. It accounts for only 0.1 to 0.5% of all ocular disease. And the key demographics show that the prevalence is 400 to 500 times greater in Africa than the northern continent. It's more prevalent in arid climates, dry, windy climates, and we don't yet have prevalence data for South America. So we can see here in North America, United States, and Canada, again, it's going to be only about 1 out of 10,000 people that we're going to see this in. What's interesting about this is that there is a relationship of genetics, but also environmental and gene-environment interactions. So there are actually 3 arms that control or contribute to the prevalence and pathogenesis of this disease. So what are those 3 arms? Well, we have environmental factors. We know that retrospective analysis of patients presenting with VKC show that there can be environmental triggers personal medical history, and family history. And we can see from each of the factors listed here that they're typical of the many clinical conditions that we categorize as allergic or immune responses. Take a look. You can see that the upper respiratory conditions comprise the largest percentage, which again would kind of fit with the ocular manifestations given the tissue similarities. These are mucous membrane tissues, and so we can see that the medical history and the family history, we're dealing with mostly upper respiratory aspects, asthma, rhinitis. We can get some dermatologic aspects as well, like eczema and urticaria, which is itching. But again, it's mostly upper respiratory comorbidities in addition to the ocular. And again, in the arid climates, you can have sun, dust, winds, and other factors. So as we now think about the tissue components, we can delve a little bit deeper into the cellular mechanisms. And we know that the sequelae of the immunopathology include vasodilation, vascular permeability, inflammation, mucus secretion, and tissue degradation. But these are all mechanisms similar to seasonal allergic conjunctivitis. And this is supported by the high prevalence of personal or family history of atopy. What's interesting, though, is that Bonini and others have reported that almost 50% of VKC patients are negative for the above IgE-related factors. So we now know that this disease is actually based not just on a humoral response, but of a cell-mediated response as well. And so based on recent immune studies, there are non-IgE, what we call T helper cells of the type 2 variety, which are driven and shown to be central to VKC. And so we can see that it's a multifactorial disease, both with IgE and Th2 mediated. And here you can see the arms of these immunologic responses. So you have your B cells, which are your cellular response, and then your humoral response being your eosinophils. So you have all of the mediators that we're familiar with classical allergic conjunctivitis, but you also have some cellular reactive species there as well. So what actually happens in the disease course? If we have a patient with this, what can we expect to see at the beginning, as the disease progresses, and then later on? So in the beginning, it could be very, very difficult to diagnose, and Dr. Halleran's going to go into that because of the fact that there are so many similarities with seasonal conjunctivitis. What do we see? I mean, we can look at this eye on the left and go, okay, I mean, I'm seeing people walking around New York City now looking just like this. You know, there's itching, there's erythema, chemosis, edema. You can touch an animal you're allergic to and, rub your eye, and this is what it'll look like. But the thing is that this is not an acute, short-acting thing. This is a disease which is unremitting, unrelenting, and aggressive and progressive. So days to months later, you're going to see reappearance of initial symptoms, but you're going to start to see more serious sequelae where you're going to get disruption of the ocular surface. And then months to years later, we're going to talk about some very serious effects that occur later on in the later stages of the disease with continued inflammation and true ocular surface damage. And it's that damage which then has the visual consequences, which is why we consider this a sight-threatening disease. So the disease can present in actually two different ways, but often, or there can be a crossover or a combination. So here in North America, we're more likely to see this cobblestone papilla on the superior conch. You can see, you can't miss this. Another reason, and if I have said it in any of my contact lens or anterior segment lectures, please avert lids on every visit, no matter who you're seeing and what age. It is just so important, but particularly in children that present with symptoms of seasonal allergic conjunctivitis. So even though we already talked about the fact that this was more common in children in the sub-Saharan Africa, we have a global world now. These people are traveling, and in addition, what we also see, because of the genetic component, we can have children of populations that are born here, who are still predisposed to this condition. So evert, and take a look and make sure you don't see this. More commonly seen in Africa and West India is the limbal variety, where you actually get a broad, thickened, almost like gelatinous appearance around the limbus. It's rather marked. It can be subtle at the beginning, but that is what you're going to look at. You know, it can almost have the appearance of the beginning of a limbal stem cell deficiency type thing, but that would be unusual because that's rare in children. So what are you thinking? You're thinking some sort of immune or IgE-mediated response. So that brings us to these children. And, you know, we all have empathy for adults who have diseases and later onset diseases. But when something like this affects younger children, I think it really kind of more tugs at our clinical heartstrings. These kids are miserable. They're itching, they're photophobic, they're burning, they're tearing. You know, some of them have to walk around in these dark glasses, their eyes are red, there's mucus. It really does have quite an impact on their ocular well-being, their ocular health, and also their quality of life. So it can affect everything a child wants to do, and you know, particularly because it is more prevalent in the warmer climates and the warmer times of the year. These are the times when kids want to have more fun, and this is really something that interferes with the fun. You know, swimming, sports, meeting friends, playing outdoors. It can affect visual performance for kids that suffer year-round and who live in these warmer climates. So, you know, much like asthmatic children, I liken this condition to that, where those children are very limited. Well, this is, you know, very similar in its quality of life impact. Let's talk a little bit now about the more visually related aspects of this disease. So it kind of runs the gamut, as I mentioned before. You can start off with just, you know, a punctate epithelial keratitis. You know, and if you see a mild keratitis, you kind of might just sort of blow it off and say, gee, the kid might have been rubbing their eyes, or they got sunscreen in their eyes. It can present like any mild surface inflammation that you might see. Certainly, if you're seeing a contact lens wearer, we see these all the time. But you know, you have to kind of relate it to the age, and again, flipping the lids and looking at the limbus to make the differential diagnosis. If you start to see filaments, I think all of us would be on a higher alert for something, you know, more of a disease process going on. Shield ulcers occur when those papilla under that top lid become very, very prominent and actually start to erode into the cornea, dig in, and you'll actually start to see a translucent base, much like the picture here. And it's called a shield ulcer because it has that shape of a shield. It could look opaque, yellow, white. Eventually it becomes elevated and it will start to scar, but it can continue to rub down, erode, and scar. So these kids are in pain, plus the fact that obviously it can affect the vision. Then other aspects you can see would be keratoconus, which makes sense from two perspectives in my mind. One is that we associate keratoconus with atopy, as most of you know. But the other thing is, what else is keratoconus associated with? Rubbing, right? So these kids are constantly rubbing. So we don't know, is it a chicken or an egg thing? We all know to caution our patients our allergic patients against rubbing their eyes, especially our young patients, because there is a relationship. And again, you can see limbal stem cell deficiency, and eventually, because that limbal response in the limbal arcade, the vascular response is so great, you will start to see vessels filling up, either micropannus or 360-degree neo. The other thing that you can see is something called the pseudogerontoxin. And this actually looks like a patch of arcus senilis. It's usually located in one quadrant, but it's very prominent. And that is really pathognomonic of this disease. It shows that the limbus has really been affected. And again, remember, the limbus is where all of the vascular and immune cells reside. So what are the frequency of these complications? You know, these kids that go on to develop this corneal scarring. Well, we can see that corneal scarring is the most frequent complication that gives visual impairment. The good news is that most of the time it's mild, but it can be severe. And that occupies the largest percentage of visual impairment. What's interesting, though, the next most frequent thing, which is keratoconus, leads to the most severe visual impairment. And I think most of us can understand why, because along with the potential for these shield ulcers, you also have the ectasia. So again, corneal scarring and keratoconus are the two most contributing factors to visual impairment. So I'm going to just summarize now. We've learned that it's a severe form of both humoral and cellular responses. It occurs in predominantly male children younger than 10. It is year-round. There can be times when it's exacerbated. The symptoms are incredibly disabling. Mucus discharge, tearing, redness, itching, foreign body sensation, pain. Complications can run from, amblyopia, which is almost really a pseudo-amblyopia. Corneal ulceration, perforation would be really rare, but it can happen. There can be glaucoma that would be secondary to corticosteroid use, and it definitely has, unfortunately, on children, a very negative impact on quality of life, social and educational outcomes. So I'm going to turn this over now to Dr. Halleran, who's going to take us through some of the challenges of diagnosis, as well as teaching us how to treat this condition. Dr. Halleran.
Dr. Resnick. Right, let's see. Okay, so as Dr. Resnick mentioned, I'm going to take us through looking at diagnosis of VKC in a patient, as well as taking through a case that was a really good learning experience for myself and other doctors in my practice, and ended up working very well with lining up with some of the challenges that are present when dealing with VKC. So to kick it off, we're going to chat about this patient, talking about the first time that she ever came into our practice, which was back in March of 2016. She was 12 at the time. And she came just for basically a regular eye exam. She'd been having trouble seeing the smartboard in the classroom, but it did happen to mention, oh, yes, I have severe eye allergies in the summer months. And she was, at that time, just diagnosed with simple myopia and seasonal allergies. And I think at that point, really had never tried anything on her eyes. She just took oral medications. But over the course of the next 3 years, she was seeking care in our practice, basically May through August, every single year. Watery, itching eyes, discharge from the eyes, hyperemia, all of those things Dr. Resnick just mentioned, including the papillae as well. Treatments were pretty standard for any allergy at that time. Cold compresses daily, lid scrubs if the lids were involved. Sometimes we were using Cataday or something of that nature. Artificial tears, of course. There had been a course of loteprednol. Again, a short course trying to take care of some of that inflammation that was present. And often we were recommending that she also take antihistamine, or she was already taking those on her own. Fast forward to July of 2019, she's now 15, and came in unable to wear. She had been a contact lens wearer up to that point, not for very long. However, I do remember her coming in and saying, I really can't wear the contacts now. I think we did her in the fall, and now it was summer months. Eyes were itching, not relieved by her drops that she'd been given. She was seeing well still at that point. Her optometry readings were always good. However, on this visit, noticed that there was significant anus, and as well as she was getting that limbal involvement and upper lid papillae, GPC, as well as the lower lid papillae. So similar to that image, there is not her eye, but very similar to that presentation when she arrived at that visit. So looking at the clinical features of all ocular allergies, I mean, we already talked about this with Dr. Resnick mentioning that VKC does have some specific things about it, but across the board, all of the allergies are very similar to one another. However, it's that GPC, and then when we start to get that limbal involvement, that VKC comes more to mind. And always at the back of our mind need to think about VKC because of the visual involvement that may come from that. So constant erosions on the cornea, ulceration, plaque involvement, things like that, then we need to be worried about where is this going to go, especially where it's occurring in childhood. We need to be sure that we're recognizing it if it's happening and treating it appropriately. This scale is not specific to VKC. There really aren't scales specific to VKC, which is one of the clinical challenges. However, you can use a scale like the Ulcer scale to gauge severity in terms of what are the chances that we're going to get this limbal involvement, what are the chances that we're going to have visual change in this patient, and you would use vital dyes to determine where you're at in the grand scheme of things with this scale. Bonini, who is a ophthalmologist or a professor based out of Italy, has done a lot of work in VKC specifically, in a lot of allergy, and did come up with kind of a mild, moderate, severe, very severe rating scale for VKC. You first have to recognize that you're dealing with VKC before you're going to place it in one of these categories. And if you look at mild VKC, occasional short-lived symptoms, mild conj involvement, papillary reaction, a little bit no corneal involvement. I mean, that's just going to get labeled by most clinicians as allergy because it's just present as such. Moving into the more moderate, severe, very severe, then you're looking at more issues at the actual corneal surface. And that might be when the light bulbs start to go off. Again, inverting the lids, and I'm so glad that Dr. Resnick mentioned that. I had that in my notes to say, make sure that we talk about inverting lids. It's one of the most important things we can do for all of our patients. But in terms of any chance of diagnosing VKC, going to lids. This was a study that was done just looking at which risk factors equal the chance of poor visual outcome. Because again, VKC does have that potential for vision and irreversible visual change. But of course, if the more severe disease we're seeing, the more chance that we're going to have more visual outcomes, call it corneal ulceration, the limbal involvement. Once we get to these points, we're much more likely to see that patient at risk of visual impairment from the disease process. Okay, so our challenges with VKC, often these patients are suffering for a very long period of time. So even if we think back to that patient, and that patient's going to come up again now and shortly, it was a 3-year time span between the first time we saw her and over a period of 3 years, we were diagnosing and treating ocular allergy before maybe we were seeing clinical signs or thinking VKC for that patient. There's a big overlap between.
And Claire, could I just stop you for a second? Your audio is cutting out a bit. If you could just please, I don't know, maybe get closer to the laptop, or
Sure.
I don't know if that'll help, but we can give it a shot.
Okay, give it a go.
All right, thanks.
Okay, no problem. Just chime in if that's still an issue. Okay, so back to challenges with our VKC. So, what we're dealing with here is a disease process that is very much like other ocular allergy, and so there's a large overlap between the symptoms and signs of VKC and other allergic kind of diseases. No two patients are alike when it comes to VKC presentation for patient to patient, and there's really no standard diagnostic criteria coming to mind all the time. Like, oh, I see that, it must be VKC. because when they're mild in the disease, it's looking like other things and it's not necessarily at the forefront of our mind. Is that going to change tomorrow in your practice? Maybe not, but looking back through the years of a certain patient, if you're lucky to track a patient for a number of years, you may start to see these signs coming out. And so it definitely should be something that is in the back of your mind when you have a child with a fairly severe disease or allergic process occurring. So we're back to this case now. And again, the July visit, she's 15, she's complaining more so about the contact lenses not being comfortable. A little bit concerned about that. It was at this visit that I started to recognize the patterns that had been occurring over the last number of years. Again, it was the clinical sign of seeing that trantistods and the limbal involvement that caused that light bulb to start to go off, and realize, oh, this patient likely has VKC. Of course, she was ticking a lot of boxes in the unlikely category. So she was female, she's 15 at this point. I live in Newfoundland in Canada. It's not subtropical here. So all of these things weren't necessarily lining up. However, if any of you listening are in rural practice, you can't throw anything out the window because anything could walk in your door. Not saying that doesn't happen in urban centers either. Of course it does, but when you're one of the only gigs in town, anything could really show up at any time. And it might be a one-off event, but it happens. And again, back to this, our challenges here. We have a patient, okay, now we recognize there's VKC maybe, but there's no gold standard treatment for VKC necessarily. There's, a lot of the first line treatments are palliative. We had already tried a lot of those with this patient. And so, we had tried that short course of steroids a long time ago. And then after this appointment, had introduced stronger steroids in order to control the disease. She really just was so uncomfortable. I think I remember saying to her at that visit, this is a significant problem for you. She's one of those patients, doesn't necessarily complain a lot, just sort of says, oh yeah, I have really bad allergies. Once you see limbal involvement like that, this patient is suffering and has been suffering every summer. It just becomes their norm. And it was only at that point that I realized, oh, I have not been serving this patient probably in the best way possible. And so if we go back to that Bonini scale, now looking at the different treatment options that we have depending on severity of disease, again, at that mild stage, you're looking at avoiding anything that causes the allergies, which can be a challenge in the summer months when all the kid wants to do is be outside and that's what's causing your disease process. Lubricants, antihistamines, mast cell stabilizers, the pretty standard across the board allergy type treatments. Once you get into that moderate, that's when you might look at posting a steroid. Maybe if it was long-standing or multiple years of it is ongoing, to think about an immunomodulatory medication at that point. Once we get further along in the process, then really looking at those immunomodulatory drugs that are available, cyclosporin. Tacrolimus, in Canada, we don't have the ophthalmic version of tacrolimus. I don't know about it in the US, but I know in veterinary medicine they do have something for ophthalmic use, but that can be compounded. Topical steroids, of course, are readily available and something that a lot of us would use in that case, I think. Of course, once we get to the very severe disease where the cornea is very involved and the lids are extremely involved, then that's when you really need to involve surgical options, most likely. So, of course, preventative measures, non-pharm strategies, when early in the disease, you're going to educate the patients about what's going on, why they're feeling this way, what's causing this. So, teaching that patient about how allergies occur and why they occur, and what we can do to avoid exacerbating the issue. So avoiding rubbing and touching the eyes, avoiding being out in that pollution, around the plants and flowers that are causing these problems, around the pets that may be causing problems. And then talking about like washing of the pillowcases and washing the face and hands and hair, using things to protect their eyes, visors, goggles, hats, and then symptom relief, not, cold compresses, preservative tears. So at the end of the day, that's kind of what we're going to start with a lot of the patients, especially mild disease. Then, of course, we move into adding into topical steroids, mast cell stabilizers, antihistamines as well, which could be really helpful like this. However, there are side effects to be considered, especially when it comes to steroid use. So I have found, and we will find that most of these patients will get a lot of relief using a corticosteroid. However, sometimes this disease also isn't there all year round, and so some of the patients will self-medicate or keep steroids on hand. I find this happen a lot, is they still have a little bit left in their bottle, and they'll get a refill or something, and then they'll be using it randomly when the eyes are bothering them, and their eyes tend to flare up really easily. And so you do have to be cautious when using topical steroids in these patients and make sure they're aware of some of the side effects that may occur. Because again, these are sometimes become young adults, and they're just sort of dosing as needed, and sure that they're aware and that we're not prescribing bottles of steroids, or maybe considering other options that have available. So I know in pediatric ophthalmology, they had been compounding cyclosporin to different concentrations for this specific disease. However, recently, FDA approval of a VKC treatment of 0.1% cationic emulsion has been granted for VKC specific treatment. Okay, here we are, back to my patient case. So we've decided now that this patient's likely been suffering from VKC for an extended period of time. Discontinue the contact lens wear, of course. We did continue with the day, and then I did start her on prednisone 1% 4 times a day for a week to see if So you can see now the date is January 2021. So this past January, this patient presented to me. This was the first time that I had seen this patient since 2019. And again, the pandemic had a lot to do with that. So she returned really for a routine exam and mentioned that she'd been able to get some refills on the prednisone over the last year during allergy season. Via like a phone call telemed with the doctor and sort of mentioned, oh, I need some more of this drop, and I can't.
Yeah, and Claire, could I just have you stop for 1 second? Your audio is cutting out again. If you could just move closer and just kind of, there you go, as close as you can get, because you're cutting out there a bit. Okay, sorry about that.
I'm just going to get real intimate here.
Yeah,
okay.
Great.
Okay. Okay, so yeah, basically what's happened is this patient disappeared for an extended period of time, mostly because of the pandemic and inability to get in to see. Was able to get some refills on her predacetate from her family physician. She did find that that was always working well for her eyes. When I saw her, she was still seeing well. Her tonometry was good. However, I happened to notice that she did have some cataract in each eye. So again, this patient's quite young. And then we chat more, and yes, there was definitely increased use of the steroid. And I come to state that most likely we're seeing these cataracts from steroid use that she's seen over the last year. So we did a follow-up in 3 months because this was January, and she actually wasn't suffering from much in terms of the allergy at that point. She typically would start to see the allergy occur in April, May month. So I said, let's follow up in 3 months, no steroids, and we'll consider a treatment without the steroids at that time. So at that appointment, I did prescribe her Acacia, which is a cyclosporin 0.1% solution, so a cataract emulsion. Here you can see that a study was done that has led to FDA approval of this medication. It's very effective in improving the corneal staining. It's effective in lowering use of other rescue medications like the steroids, and significant improvements in VKC symptoms and the quality of life of those patients. And we have found that in this patient, so we've been able to go without the steroids and still have the use. There we can see that we started on that March to October, and that we will annually use that medication until she's no longer suffering from it. However, she's fairly old at this point and still does suffer from significant allergy, and so likely continue to use this. So in summary, we need to obviously chat with these patients about avoiding any allergic triggers and planning lifestyle. You know, easier said than done when you're talking about a kid who has a short summer to enjoy, but then we want to really consider therapeutic options and approaches based on the disease severity and personalize it to the patient. And a multi-pronged approach, pharmacological approach, is needed, so there's no single medication that's able to treat all aspects of VKC. However, now we do have a treatment that's specific for VKC that should certainly be considered earlier on in the disease process instead of having to use more of the severe or likely to cause complications of the steroids. So knowledge and understanding of the benefits and limitations on the use of the various therapies available imperative to successful use. And I believe that statement. All right, so now Dr. Resnick's back. Hopefully you can hear me. Doesn't matter how many checks we do, it's still in the moment decides that it doesn't want to work. So there we go. All right, so I'm going to bring up that slide about all right, so we're just going to do a little discussion now about some of our goals with VKC and how we're really, it's not only to improve quality of life, but also prevent those long-term complications, right, that we are certainly need to be concerned about when it comes to these patients. Luckily, my patient, you know, we did see that limbal involvement, but never got to the point where I was worried about her corneal health. Kind of jump on it, and because she had been complaining, and we had gotten the steroids involved, you know, we were able to kind of avoid that. But now we have that new added complication of the steroids, or steroid-induced cataracts, I should say. So that was an interesting case, and I was so happy to have something that I could switch to that I felt confident in, you know?
Yeah. So, I mean, I think about this, and, you know, again, because it has so much similarity to seasonal conjunctivitis, some of the therapies we use for that are really good first line as well. So getting cold compresses, limiting that vascular response, putting artificial tears in the refrigerator. Claire, I would wonder, what's your opinion on sending these, because we want to also control the environmental factors, do you send these children out to allergists for testing just to see what they specifically could avoid? Do you co-manage with an interdisciplinary team with allergists? Because I know there are so many like monoclonal antibody type drugs now that actually reduce the eosinophilic reaction. We know that that's only present in about 50% of these patients, but if it's 1 out of 2, I think if there is a high eosinophil level, are we looking to get them on some non-steroidal oral medications as well as the Verkasia?
I think that that's a really important thing to consider because, I know where I'm currently located, it can sometimes be challenging to get in to see an allergist in a timely fashion. And so often we are still trying to manage the disease as much as possible. Here I from personal experience know that it can take about 6-7 months to get in to see an allergist, So I think it's a good thing to consider for sure. And I do think because there are ways that we can specifically target certain things and knowing, okay, I am definitely allergic to these things. And that's what's really driving this. Then we can truly avoid the triggers because a lot of the time it's a lot of guesswork, right? But if we can take away some of that guesswork, I think definitely that multi-pronged approach and as specific as we can get it makes sense.
What do you think about using if it did get to the point where they had the papilla was so great and starting to cause a shield ulcer? Would you consider using a contact lens as a bandage kind of thing or preventative in terms of corneal erosion?
I think in theory that could certainly work, provided maybe the lids were in a state where they could handle it.
Right.
Because even my patient, that I don't know if I mentioned, but they were daily contact lenses that she'd been using, and still we couldn't deal with it.
Right.
And so, I think maybe if there was a significant ulceration, or maybe we would consider an amniotic membrane or something in that situation, right? To try to
Yeah.
and then maybe a scleral, I don't know, but we would have to really look at what's going on with those.
And then also,
lids, right? How thick they are. And
if there's limbal involvement or there's any aspect of potential limbal stem cell deficiency, I would be cautious about a scleral, but certainly, maybe during the day a bandage lens of some sort. But again, we would hope now with Verkasia, which again, just to repeat what Claire said, this is a brand new compound of cyclosporin. It's in a base that makes it highly permeable into the tissues. It's a 0.1%, and the cationic emulsion makes it much more compatible with the ocular surface. So the good news about this is that this is actually approved specifically for the use for VKC. So it's so nice to have things that aren't off-label anymore, although obviously we rely on off-label a lot in optometric and ophthalmologic care, but when something's approved, I think it gives us all a greater degree of confidence in the drug. We saw the results of the testing. The long-term results were excellent. The study included 2 different concentrations, and they were able to determine the amount that worked in the majority of people without having too much or too little. So that's the beauty of having an FDA-approved drug, that we know that we had these randomized control studies. So I know that, again, I don't see a lot of it here in New York City, but with populations now on the move, it really, as I said before, we're a global medical environment now. So I do see a lot of immigrant children, and there is a genetic component. It's not always about being in their own backyard. It can be right in our backyard. And, hey, if it could be in Newfoundland, it can be in New York City.
Right. That was my thing. I said, hey, if it's here, it's anywhere. And like I said, being in a rural practice where I don't have a lot of access to ophthalmology, and my patients definitely don't have easy access, then they sometimes just end up in your chair. And so that's where it becomes having the good standard practice of flipping the lids and making sure you're going through those checks in your mind of, okay, it's checking a few of these boxes. Maybe they're not checking all these other boxes for a typical patient with it, but they do have some of those clinical signs.
Right.
And so, you know, and I think ours was a good learning case where we realized later what we were dealing with, and been treating with kind of mild symptoms. And I think a lot of us would treat the way we did, you know, the mild symptoms. I mean, that's still the way you're supposed to treat someone with VKC. It's just recognizing that, you know, talking about that third bullet there, you know, scheduling those visits before that offending time of year. If you know you're hearing from patients, it's every, you know, May, June, or, you know, April, May, depending on, you know, climate and whatever. You know, if you know that that's the offending time of year, to try to be proactive and see those patients, you know, mid-March or something like that. I know a pediatric ophthalmologist in Canada says, oh yeah, you see those patients at the Ides of March because he is getting ready for that impending time when he's going to be struggling with that.
So because I believe in the one column or one airway feature of these atopic diseases, from the lungs to the nose to the eyes, I often have these children just using plain saline sprays in their noses without the offending, because what goes down can also go up. So well, we have a lot of nice sort of home palliative remedies, but again, that's symptomatic. But for the true control of immunopathogenic disease, the cyclosporin is the key.
Yeah, definitely. Yeah, so I mean, I never mentioned, but yes, we've had it approved in Canada for a little bit longer, so that's why I have had the opportunity to use it.
Excellent.
So, yeah, it's been super helpful, and yeah, always just that little bit of peace of mind that that we're using something that's specific for VKC in that situation. So yeah, Adam, I don't know if there's questions.
Yeah, absolutely. Well, thanks, guys. Let me pull up some questions here and get going. You know, I'm sure there's a million here that we can try to answer here. So, the first question, I guess, I'll ask you guys a more general one. So, you know, right out in the beginning, you guys spoke about how the symptoms are fairly non-specific, right? This could be like the Great Pretender. It can look like a bunch of stuff. So for the doctor who maybe hasn't been on the lookout before and will be on the lookout now, what sort of diagnostic testing might you do when you have the patient in the chair?
So flipping the lids, looking at the lids, that we can't state enough. So yeah, I'm so glad once you said it, I was like, yes, over here. So, you know, that's really, really key, because if you're seeing the papillae involvement on the top lids, as well as bottom lids, you know, that's significant, like something's happening in that eye. So we need to recognize it. And I find for myself, I'm a little more concerned if I see it on top lid than if I pull down and see a little bumpiness at the bottom. I don't know, that's kind of how I feel.
The other thing I would add, Adam, which is not typical of your garden variety seasonal allergic conjunctivitis, is to use diagnostic dyes, because you don't, I'll use the word, almost never see corneal or conjunctival staining with seasonal allergic conjunctivitis, but you will see it with this due to those papilla, and also due to the inflammatory response. So you also have to look at the limbus very carefully. So we're used to seeing chemosis and injection of the conjunctiva, but you have to also look at the limbal vessels that are deeper into the cornea. If those are starting to dilate, I'm then concerned that there's a greater immune response occurring. So exactly what Claire said, flip the lids first, look for papilla follicles, and then you want to use your fluorescein staining, as well as a careful inspection of the limbus.
Yeah, bump that mag up if you've got to really look at that limbus, see what's happening.
Yep. And after you've made the diagnosis, if you have a patient who's kind of mild, right? So some of the cases that you showed us are pretty severe, right? In your slides. But if you have a patient who's mild and you've made the diagnosis properly, what would you do for treatment?
So I think I would still start fairly palliatively, but I'm going to be on that person a little bit more. You know, I'm going to be making sure I pre-appoint that person, maybe do a check-in phone call, maybe even if they're coming to see me early spring, starting to see some, I'm going to book them out a couple of weeks out or a month out and sort of see what's happening here. Are these treatments working? So I think it's about, you're still going to use those palliative sort of treatments, so the cold compresses, the like cold tears, avoiding the allergens, maybe starting the allergist process, get them seen to. What do you think, Steve?
Yeah, I would start with mast cell stabilizer antihistamine combinations right away. It's clear that you move the treatment regimen, you want to narrow it, you want to get, you want to almost treat a level 0 with a level 1 treatment, because you want to get on top of it. Once this cascade starts rolling, it can kind of get out of hand very, very quickly. So I would, just as Claire said, start with the palliative stuff, the preventative stuff, but get them on a mast cell stabilizer antihistamine. What's interesting, a lot of the first and second generation mast cell stabilizers actually work better than some of the newer ones for this, which is kind of an interesting thing. We don't know why, but that's maybe because it has more stabilization effect than antihistamine effect, so you're getting it earlier in the cascade. And I wouldn't let this get too out of control, because cyclosporin is such, I'll use the word safe drop. I wouldn't hesitate to put somebody on it, very, very early in the treatment process.
Yep, absolutely. And you mentioned that this can spiral out of control. This is a really good question that someone had. So when you have the patient in the chair, how do you educate them about this, right? Because they're thinking, oh, I have an allergy, who cares, right? But this can be vision threatening. And this is probably something they've never heard of, right? I'm sure many ODs actually probably don't think about this at first either. So how do you actually get that across to the patient that this is really something not to mess around with?
Well,
I think, yeah, and I was going to say, I think by telling them that that you have a concern, that you are monitoring this for a purpose, I think, again, by maybe pre-appointing them out or stating like how important it is that they follow up care with you, they'll recognize like, oh, this is not just my garden variety allergy, or, you can say to them, it's not everybody suffers from allergy like you do, and this is unique to you, and you need to make sure that this doesn't spiral out of control, because it could.
Yeah, I would, if, look, it's a child and you have the parent, so you want to talk to the child first and the parent as well. And I would explain to the child that, caution against rubbing, that is key, because that's what breaks the membranes of those mast cells. So no rubbing. If they feel the urge to itch, get a drop in. So anytime they want to itch, put a drop. But to let them know that if it gets out of control, they may not be able to go to this, go swimming or play basketball or spend as much time on the computer. You want to kind of bring it home to what they like to do and tell them it may interrupt their pleasurable activities. So that's how I always work with children. To the parent, I would do exactly what Claire says and say, make sure you bring Johnny in 2 weeks. I need to look at him, and maybe show a picture of one of these slides of what that inside of the lid could look like if we didn't treat this aggressively.
Right. And question here, a more complicated case, patient wearing contact lenses. So how do you deal with this? And what kind of lens do you try to push them to if they're going to try to keep wearing their lenses?
So a daily contact lens for sure.
Right, it has to be a daily. You want to work with a lens that doesn't move too much, because understand that those papillae are going to cause that lens to jump. So you're going to fit it a little tighter so that it protects the cornea and doesn't rub. There are some people that, not so much now with the newer lenses, but some of the silicone hydrogel lenses can be a little bit less appropriate for these. So oftentimes I will stick with a HEMA-based lens or a very low modulus lens for these patients. The other thing,
just for the stiffness, yeah.
Because you want a really thin edge. You don't want any mechanical irritation to those lids. The other thing I would say, and here's where I would go off-label, I would have no qualms about using their drops during the day with those lenses on. As a matter of fact, I would advocate it. Those lenses can act as a reservoir for the medication, which would not be the worst thing in the world. I am not concerned about preservatives in a case like
Right.
this, lens that's being thrown away. I'm more concerned about getting the drops in and having the kids see during the day. Of course, I would prefer them to wear their glasses, but the way you phrased the question, Adam, that would be my answer.
Yeah, I thought about this a lot. I was thinking about that actually. I'm glad it came up because, especially in the day and age of myopia control and how much we're thinking about that and doing that nowadays. Luckily, a lot of those lenses that are coming out are daily lenses, and so it lends itself to that. But yeah, it could be an interesting cover.
Right. And in terms of compliance, right, it becomes that much more important if they're wearing a daily disposable. Will you actually cut down the number of lenses you prescribe to make sure that this patient's being compliant with it?
Yes.
Good question. Would I do that? I don't know. I mean, it might be a good idea depending on the patient.
They're going to get them if they're going to get them anyway,
Right.
That's a whole other topic.
Right,
Yeah.
right. So question, we mentioned now that we do finally have approved treatments for this. And I guess the question is, we're talking, obviously Santen sponsored this today, the availability of the drugs. So maybe, we have an international approach here tonight, right? We have Canada and the US. So maybe you guys can speak to that a little bit.
So the drug will be available. It has been approved. It's not available yet. We are anxiously awaiting it. I know Claire has had the privilege of working with it. I have not, but that's I have my shelf dusted off for it.
Yeah, ours got approved just before pandemic life, and really I've only been using it clinically for 6 months or so. But yeah, I mean it's been available here for a while, and I think it's going to just be a lovely tool in our toolbox that we can pull from across the board, right?
Yep. And so I guess the important thing, if people really want to learn more, talk to the folks at Santen about it directly,
Right.
And they can probably, get you up to speed way more than we can, I would imagine. All right, cool. And so those are just some of the biggest questions. One clinical question that actually a clinical question or more of a comment. So it's common in Middle East countries, VKC or VCK. But the question is the glaucoma from the long-term use of topical steroids. So what do you do? And is this going to be a thing that people are going to have to deal with in this particular case, especially because they're kids, right? I mean, the nature of this disease is that it can sort of smolder for a while.
Yeah, I mean, I'm definitely in the practice where I would be checking that tonometry, and you noticed on my case, tonometry was always something that was being checked because steroids had been involved fairly early on in her treatment, even in lotoprednol, but then later as prednisolone. And so I think we need to monitor that, and if you are seeing steroid response in terms of increase in IOP, then that's really another reason why it's great that we have more options where we don't have to use a topical steroid, and that might be where we need to involve, more oral treatments and be more specific about treating specifically which allergies we're dealing with.
So if you discontinue the topical steroids, Adam, the pressure will come down. Look, you're going to have to use them pulse dose, but the good news about some of the softer steroids now, the ester base versus the ketone, is that you really don't get an IOP response. You can be on lotoprednol for months, honestly, and I've had patients on it, and you have to check, but usually there's no response. If there is a response, you almost have a little bit of a benefit to tell the patient that they may be more prone to glaucoma when they get older. We know that there's a relationship, but it rarely would interrupt the treatment of these patients because hopefully they're just doing it on pulse dosing. You never want to give a refill, so they're not holding these bottles and self-prescribing, and you're keeping close tabs. If the pressure were to go very high, I would have no qualms about putting them on a glaucoma drop concomitantly if I needed to.
Really? Okay. And I guess, again, compliance is really the huge issue here, right? And keeping on top of these patients, probably even more so than you would most others.
Right.
Great. Okay. So I think that probably wraps it up because we're running out of time here, but I want to forward the slide here if I can. And, I want to obviously thank both of you for being here today. This was really great. It was fantastic doing something a little bit different, right? Learning about stuff that we usually don't get to hear about. So this was fantastic. But I'd also like to actually put up a slide here to show folks if they want to learn more. The folks from Santon are actually here tonight. And Stephen, are you there?
I am, Adam. Can you hear me?
Oh, yep, I can hear you perfectly. So, thanks so much for being here. And I put up a slide. Hopefully everyone can see it right now. You folks are going to be at the Academy meeting, right?
We will indeed. As a matter of fact, first of all, I want to thank you for the opportunity tonight, and thank you to Dr. Halleran, Dr. Resnick. Incredible mastery of the material, and thank Claire for sharing your experience. You're right. It has been available since November of 19 in Canada. And Dr. Resnick is correct. It is approved in the US, and you manage that very well. We want to make sure the product's going to be available when someone wants to write that prescription. So we will communicate that. It's not quite out there yet. Some wonderful coverage of some questions that we have got in Canada. I've been privileged to support that. Contact lens were an exclusion, by the way, in the Vectis trial that you shared, Claire. So I enjoyed that discussion. And particularly this patient, we know that we are very much focused on this patient caregiver focused materials to help with things like compliance. Why is it important to get your doses in? And so those things are in the works too. But yeah, particularly Adam, what you mentioned, we do want to share more on this, and in particular 2 activities. So on November 3rd at the Academy meeting, we're going to have a lunch symposium where I think we're going to share a little bit more data from the pivotal Vectis study. Dr. Resnick, I think he'll be there with us, yeah. And Dr. Halleran couldn't travel quite yet, but we will miss her. And then sometime over that period, we will have to introduce Santon, our work in the front of the eye, particularly in VKC, and also our other therapeutic areas, what we call our scientific open house. This will be an opportunity. This is a medical invitation to meet with some of our high-level medical leaders, indeed from the globe. And so keep your eyes open for that. There'll be some invitations coming out. Again, Adam, thank you for wonderful moderation. Doctors Halleran and Resnick, thank you so much.
Pleasure.
Great.
Sure.
Well, thank you, Stephen. And again, hopefully we'll see everybody out in Boston. It's going to be great to see everyone in person again after a couple of years where we're all kind of just zoomed out. So and it'll be wonderful to see all of you there as well. So again, if there are any more questions, by the way, the archive of this will be posted at ODwire as soon as we can. And so if you happen to be watching this on ODwire, feel free to type some questions right beneath the show, and we'll get back to you as quickly as possible. So again, thanks everyone for being here, and I look forward to seeing everyone online.